All right, everybody, please be advised, this is a public meeting that's being recorded, and so anything said in the chat or viewed with the cam or verbalized is going to be captured. All right. Oh, it's still not red lighting me. Oh, there we go. All right. Dr. Rice, take it away.
Perfect. All right. Thank you guys for all joining our work group. Normally we have a little bit more hefty draft to work off of, so we're not going to have that today. So I think what we'll do is kind of introduce ourselves, and then we'll kind of work through maybe sort of like the outline of what this educational activity will be, and then see where we want to go from there. So I'm Amber. I chair the education committee, so I'm here today to help out.
I'll go next. I'm Shelley. I'm the services section administrative coordinator, and I help support all these meetings. Adam?
I'll go after you, Shelley. Hi, I'm Adam. I'm the state's Emergency Medical Services for Children coordinator, and I have recently come out of the field from being a paramedic, so hopefully I can help out.
Great.
My name is Matt. I am a paramedic and battalion chief at Guardian in Flagstaff, and I am also on the education committee.
Hi, I'm Vivian Rubio. I'm with the Arizona Department of Health Services Maternal Mortality Review Program. I'm their clinical nurse abstractor for the program. Previously, I was a labor and delivery nurse, but it's been a few years since I was bedside.
Perfect.
Hi, I'm Clark Bear. I'm the Maternal Mortality Review Program Manager with ADHS. And it was one of our stakeholders who brought this idea or this question to us to ask about maternal resuscitation and what the practices were in Arizona. So thanks for taking this on. We really appreciate it.
Yeah, absolutely. Okay, so as I sort of dive into some of the literature, I mean, a couple things come to mind for this presentation. I don't know what your guys' thoughts are. I think obviously CPR is important when we talk about maternal resuscitation in the field, but there's really not a whole lot extra to maternal CPR than regular CPR. So do you guys know those folks that came from the maternal work group? What sort of did they have in mind when it comes to this presentation, and what sort of education they were hoping that paramedics would get out of this?
Sure. I think the biggest concern was, I'm sorry, Clark. I thought the biggest concern was the uterine displacement during resuscitation of anyone who was noticeably pregnant 20 weeks or greater. So making sure that uterine gets displaced during chest compressions.
Okay. What else?
Honestly, I think that might be it. That, and on the resuscitation side, that's probably it. I don't know if you do, or how you work with your agencies about levels of care and determining, like if somebody is in an obstetric emergency or something like that, determining where they go. But that did not come up. I don't know why that just kind of clicked into my mind right now. Mostly it was the uterine displacement. And again, the observation came from just when we're doing our mortality reviews, we do review all motor vehicle accidents and other types of accidents as well. So there have been a few instances where, you know, we're reading through and reading the EMS reports and things like that, and just we don't know if that's a common practice or something that is being practiced in the state. So,
okay, do you want to comment on any of that, Matt?
No, I was going to say the 2020 AHA guidelines have a pretty good flow chart of care for the maternal patient, and that might be at least a good place for us to start, because it does touch on the displacing the uterus and the baby from the belly. Yeah.
I mean, it's hard to make a whole lecture just surrounding that. So I definitely think we need to expand upon just CPR probably if we're going to make an entire presentation about this. So any other thoughts?
This is Adam. I can tell you. So I'm also secondarily employed, as I think most of us are. We all have side hustles. I also work at Pima Community College, work at their paramedic program, so I can speak to the portion of this that comes from the educational side, and we have been and still currently are teaching largely what you guys have been saying. I'm just reflecting back to what you've been saying in terms of there's no real major difference between maternal resuscitation, with the exception of that displacement to get off that vena cava. But otherwise, we're not teaching any different techniques or procedures for these I guess highly pregnant patients.
The other idea that we just had, and again, we're new to this group, so if this turns out to not be relevant, that's totally fine. And if this ends up being an easier task than we thought, that's fine too. But we have been working really closely with all of our birthing facilities, OBGYNs, and now we're about to start working with emergency departments on postpartum warning signs. So it's not necessarily related to resuscitation, but for women who are pregnant or have recently been pregnant, there are different thresholds for blood pressure and different signs to look out for. We've got some education on. We've been working with our home visitors and things like that too. So I don't know if that makes sense to throw into this if you're trying to expand this to broader maternal health issues.
Yeah, I mean, that was sort of my thought in general. So the United States doesn't have a document like this, but the Royal College of Surgeons has a pretty nice whole educational like packet about maternal collapse and resuscitation. And so they kind of go through. Shelley, do you mind if I take over your sharing? Is it okay with you?
I do not. I will stop presenting.
Okay. So I think what I was thinking, it only wants me to share my whole screen. Fine. I can't share my screen. I don't know. It's not letting me. It says I have to change my system preferences, which isn't going to let me do it. So maybe I can just kind of talk through the points then, and we can kind of discuss this a little bit. But in the sort of causes,
you email it to me?
That's okay. There's only like 3 slides that I have kind of put together just as a start as I was brainstorming. So there's obviously the CPR piece, which is really just, I mean, essentially like 1 slide of a presentation. But the other things that they have in there are things that would sort of span the, sort of 20 weeks on. So, later in pregnancy up until like the 6 weeks postpartum period. And so they go into the different causes of collapse being hemorrhage, thromboembolic diseases, amniotic fluid embolism, septic shock, eclampsia, and cardiac disease. So being really the top causes. And I could see potentially putting together something where we kind of walk through each of those, give a little bit of information about the, the types of hemorrhage you can have and, the pre and postpartum periods, thromboembolic diseases you could see pre and post. That can, because certainly all of these things could cause collapse and cardiac arrest. So in terms of a management thing, I don't know that there's much that folks can do for any of these in the pre-hospital setting. Typically, it's just transporting them, and the transport guidelines really are done kind of regionally. So, in the Southern Arizona region, we have identified the hospitals that provide certain levels of care for obstetric patients. And so they would go certain ones, depending on how far along they were, would go to this center as a level 2 or 3. And then just depending on what services were available. So I don't know if that would fill out a presentation enough, or if there's a need for something like that. I don't think we have much about maternal stuff on the website in terms of education. So it could fill a need. I don't know. What do you guys think who do pre-hospital stuff?
Sorry, Matt, go ahead. No, go ahead, Matt. I want to hear what you have to say.
Thanks.
I beat you, buddy.
I think that's probably true. I think there's a lot of question on, like, you've got a hypotensive pregnant patient, baby is still in. How much fluid is too much fluid? When do you start pressors? Do you start pressors? Or baby's delivered and now they're extremely hypotensive because they're bleeding kind of profusely. Obviously, we don't carry blood products in the field, so we're not going to be administering that. So how much fluid? Again, how much fluid do you want to be giving? When would you consider starting pressors? Like, I think sort of those low volume but really high risk patients that's sort of a gap in education for sure.
Okay, all right. So it sounds like it'd be worth probably putting something together that would address the sort of peripartum, emergencies that can happen. And then maybe from a practical perspective, because it would be great, like you said, Matt, to come up with something that's just like very practical. What do we actually need to know? Who can have pressors? What can we do?
Often when you call, like when we've called the ED docs are not super comfortable giving that information either. They're like, well, you should call L&D. Like, no, we can't do that.
Yeah, they can't give us medical directions. So
Yeah.
so I definitely think that could be helpful for sure. Can't think of other things. I don't know if there's anything else on that list that you guys would add, but I just have that sort of causes of maternal collapse, and then resuscitation management, and then
Yeah, maybe just like some physiology changes to consider too in the pregnant patient. Their airways are going to be difficult if you try to intubate them.
okay.
More rapid onset of hypoxia in the pregnant patient. The kind of things like that.
Okay, so
Pearls would be good.
Okay, so put in some stuff about anatomic and physiologic changes during pregnancy.
Mm-hmm.
I'll put a slide in for that. Okay, and Clark had some in the chat. This is from DHS.
Yeah, this is again. I think we're thinking about this.
Oh, cool.
I was thinking about this in a different way where, and I love the way this is going. I think it's more important. But what the list is here is these are the warning signs that we're trying to educate women, families, home visitors.
This is really good though. Yeah. No, this is really good because this will give you, this will be sort of, you got a pregnant patient and we could have a little bit about physiologic changes. We could have the emergency stuff, but we could also put in here some stuff about, if someone's pregnant and they call you for one of these things, these are early warning signs you should know about. These patients need to go to the hospital for X, Y, or Z reason, or this is what could be going on. So it's actually kind of, that would be good as well. So let me put that in here.
And just the first link is a little more in depth. The second link is just it's a one pager, like an infographic type thing that we've got available that we can you can use too as part of the materials if you needed to.
So this one's headache, dizziness, fainting, changes in vision. Yeah, these would be good to at least touch on in terms of, what could be going on. Anything about COVID? Do you think there's anything we need to put in about COVID and pregnancy?
Honestly, the biggest thing we see is it's all vaccine wise, is really where the information lies. Like, I'm not sure that, unless Vivian, do you know if there's anything different about like care or emergency care for?
Not actual emergency care, just that they're at higher risk, like they are with any kind of, flu and what have you. Higher risk for morbidity and mortality.
Okay. So there's this maternal early warning signs protocol. It's probably for obstetric providers, but.
Yeah, we are working with the obstetric providers primarily, but we are noticing more and more issues where women are going to the emergency department with a extremely high blood pressure or a headache or something like that, and being sent home and having an emergency at home after already presenting. So, so that's what we're going to be working with the emergency departments through Hospital and Healthcare Association. So.
And there's this AHRQ document, toolkit for improving perinatal safety.
Oh, I see what you're saying. Yeah.
Yeah, I was just looking to see what they had. So they have a PowerPoint here. I wonder what's in it. And Matt, what about any like special equipment or anything like that? Could you think of anything like that that would be specific on the, nothing's coming to mind that would be specific, but.
No, I mean, because unless you're like a specific like maternal transport
Mhm,
unit, you're not going to
mhm.
have like a fetal monitor.
Right.
And the rest of the equipment is going to be pretty standard probably. You'll be low resourced, right? Like it'd be hard to potentially have a crew to take care of mom and a crew separate to take care of baby if baby was to deliver. So it would just sort of be kind of adapting.
Okay. Then Shelley's got some stuff here. Mm-hmm. Yeah, perfect. Wish there was something existing out there already, but we might just kind of have to come up with some stuff from scratch. Okay, so what I have so far is talking about physiologic changes during pregnancy. Some of
I was
the
just thinking like kind of the big ones for that. 'Cause, I mean,
yeah,
obviously there's a lot.
yeah,
But like hitting like the pertinent EMS ones, you know,
yeah,
like
hemorrhage.
earlier hypoxia, coagulopathies, like enlarged like tongue and more delicate mucosa, so you can cause bleeding with laryngeal manipulation if you're trying to intubate. Just sort of things like that, I guess.
Mm-hmm, mm-hmm.
I apologize if it's been mentioned already, but perhaps a short list of medications that are approved for pregnant patients, as well as those that are not approved. Because in teaching, it always stops people in their tracks when you talk. Do you give morphine to a pregnant patient? And everybody has to take a few seconds to think about it. So maybe just a quick list of do's and don'ts with medication, just to keep it simple, I suppose.
Ultimately, though, if we're talking about like the crashing patient, are there any don't medications?
Nope.
Yeah, right. I absolutely agree with you. Yeah, exactly. Yeah, exactly. I agree with you. I meant like kind of more meds meds that are outside of the coding pregnant patient. You know what I'm saying?
Sure.
What else here? Have you ever intubated a pregnant patient, Matt?
No.
I would be very scared.
Yeah, for sure.
I guess I'd have to do a little digging to see if there's anything specific in the. I mean, because theoretically, if someone did RSI, I don't know if I wouldn't do anything different, but
I don't think so.
Maybe somebody would. I don't know.
I feel like I'd have to double check, but I feel like DAC, the Airway Consortium, doesn't have like a specific pregnancy algorithm.
I don't think so either.
Yeah, I mean, if you're thinking about RSIing, like just
RSI. Yeah. Okay. Well, go ahead.
No, go ahead.
No, I don't know what I was going to say.
I am curious though about like volume of fluids and when you would consider pressors and in what situations, because I've not gotten great answers from the physicians that I've spoken with.
That would be really interesting. So maybe talk to someone that does more on the critical care side, or anesthesia maybe.
Right.
Anesthesia OB. Okay, let me put that on my list so I don't forget it. So we're thinking and then the cardiac arrest management, and then There's probably so little literature in this area.
I would imagine.
We do work with, well, maybe we can get to that at the end in
Mhm.
terms of like what your network is like, because we do have several maternal fetal medicine specialists and others on our committee that we can reach to. I don't know if
Yeah.
there are specific folks that you normally go to for OB related things, or if it's new.
No, not if you guys have somebody in mind. I mean, that would be good to get their input, or at least some, like,
Yeah.
where they prefer we get that information. And then normally for these sort of statewide work groups, we would share some of the material with some of our other regional groups, like in the Phoenix area, Tucson area, Flagstaff area, and just see if anyone has anything that, if something was wildly out of what they would do. We did the same thing with the LVAD work group, where we kind of went all over and made sure that all the LVAD folks were kind of on the same page, so we weren't giving weird information. But I think it would be, once we get something put together, I think we could probably share it with some of our other regional groups, or through your guys's group, to see sort of what the sort of more global feedback is about it.
Sure.
And then we can kind of refine it. So I guess maybe we can assign some stuff out to anyone who's sort of interested in putting some stuff together. I'm happy to kind of curate a slide set that we can come back with and kind of put some finishing touches on, and then we can distribute that a little bit and get some feedback before we take it to the education committee. What do you guys think? I know I don't have my screen up, but I basically got anatomic and physiologic changes, the different causes of sort of maternal collapse or maternal emergencies, the biggies, a little bit about maternal early warning signs. So these are, signs that you should watch for in pregnant women, basically. Cardiac arrest management, and then other resuscitation related things like pressors and fluids.
Sounds good. Thank you. Sorry, that's my husband in the background.
So who wants to take what? Does anyone want to take a stab at any of this and send some stuff over?
I can do the anatomic and physiological changes.
That'd be totally awesome. Yeah, I don't mind taking on the sort of emergency stuff. And then would you other guys be willing to reach out and get some information about like fluids and pressors?
That sounds like fun to me. I'll shake some bushes and see what I can come up with as far as that goes.
Okay, perfect. Yeah, and you can send it either in like a Word page format, and I can plug it into slides, or you can just send over some slides, whatever, and I'll mishmash them together. However,
sure. And just to be clear, it's fluid resuscitation and pressors on pregnant patients, right? Okay.
Yeah. Wouldn't you say, Matt?
Yeah, I think that's probably pretty reasonable.
Gotcha.
Another one, I guess, would be like Pitocin. So like we have standing orders for Pitocin for hemorrhage after delivery.
Yeah.
But we just had a scenario recently where the baby was born with a blanking on the word right now, but they were being born at home, and the healthcare worker was there to deliver, but waited like hours while this patient bled out 2.5 liters.
Okay.
And the patient had already received Pitocin, so the crew was not sure, like, is there a maximum amount of Pitocin? I don't think there is, because it's a hormone. But there was like some debate, like, do we give more? Do we not give more? So that might be a good education piece too.
Okay. All right. I can include that in there as well.
Yeah.
Do you guys ever do second line meds besides Pitocin?
We don't have them.
Yeah.
No?
They're out of scope of practice. Yep. So Pitocin would be the only thing within the scope of practice for.
Yeah.
Besides pressors. So pressors for them would include, they could give dopamine, norepinephrine, or epinephrine, pretty much, or it.
Okay. And then how about for hypertensive crises? If you responded to something.
MAG is all that they would have, pretty much.
No
And
available.
nitro tablets. Don't forget nitro tablets.
Nitro, yeah. Provider of the year, Matt.
Yeah, thank you.
Yeah, no, they could do MAG, and then, I mean, potentially they could do, I mean, some of them, if it was like I'm trying to think of who would carry any kind of beta blockers. I mean, you could have potentially a flight crew that would carry something like esmolol or labetalol or something that was, that a nurse could give, but most of our trucks aren't nurse trucks. They're, paramedic units, and so they would only They wouldn't really
Okay.
have a way to treat, other than giving MAG for, suspected preeclampsia. That's in some of the, protocols would be, if you suspect preeclampsia, give MAG. And I mean, presumably that would drop their blood pressure a little bit, but.
Good. Well, I don't know how many slides we're talking here, but I can put the urgent maternal warning signs into some slides if that's helpful, just from that website or whatever.
Yeah, that'd be awesome.
Okay.
Yeah,
Sounds good.
and you can just send those over to me. I'll put my email in the chat just so everyone has it. You can send them all to me, and I'll kind of put everything together.
Thank you. And do we want to hold off while everyone's doing their things before our chair of our committee, one of our chairs is a maternal fetal medicine expert physician, so that's who I would connect you to. Do you want that connection now, or should we wait until later?
Totally up to you.
Okay. I'll talk to her about it, and we have a meeting in a couple weeks, and then when we convene again or via email or whatever, then I can.
Perfect. And if she has specific resources that would be helpful, you can send those to me as well, and I can just look those up and kind of plug them into the slides as we're sort of building the slide deck.
Okay. Perfect. Thank you. We appreciate it. I know. So this, just generally, when you're doing these kind of things, is this an option for any paramedic or EMT to take for a CEU, or like how does this work? It's
Yeah. So in general, we would put these on, once they go through the process and get completely approved, they'll go on the DHS website as like a slide deck, and then they can be downloaded and used for kind of for anyone to do training within their agency for.
Okay.
Yeah. So for a pretty broad audience.
Thank you so much.
Yeah, definitely. I think we had some good ideas, and I think some stuff that maybe isn't in a lot of other areas as well. And I'll pull up I'm sure there's some stuff from NCCP that I'll look and see what's on there because I haven't looked at it in a little while, but what exact the requirements are, so I'll see if this fits into that or if this is going to be a totally separate thing, but it would be good.
Yeah.
And then do we want to come up with a date now to do our next session, or like a time frame, and we can send out an invite later?
I think that's probably a good idea.
Are you shooting to have something by March 17th, the next education meeting?
I mean, that would be great. I mean, to make that a goal. So sometime maybe in February, towards the end of February, to have the next meeting to kind of finalize things.
That works for me.
Let's see. I don't know if you guys have specific days available.
I think the state's on a holiday on the 21st.
On
So
February
maybe
21st?
Yeah.
That's a holiday?
Apparently, it's President's Day, according to my calendar. Oh, no. That's Monday. Today's Thursday.
That last week in February, is that what you're thinking?
Yeah, potentially. We could shoot for that. I'm fairly open the 23rd.
Yeah.
Okay, let's do the 23rd. Is this time of day good?
I'm okay anytime on the 23rd.
I can do everything except for 11 to noon.
Okay, so maybe 1 to 2 or 1 to 2:30.
Yeah, that'd work for me.
Sure.
Thank you.
How about you, Matt? Is that okay for you?
1 o'clock on the 23rd.
Yeah.
That work?
Yeah. So we'll give everyone kind of a couple weeks to put a few things together, and then just as soon as you have it, send it to me, and I'll mishmash it into a coherent slide set.
Sounds awesome.
Sound good? Okay, cool.
Sounds great. Thank you.
All right. Well, thank you guys all for participating and helping us figure out exactly what the ask was, and we'll kind of work through that.
Great. Thank you.
Awesome.
Thank
I'll send
you.
you guys. I'll send a reminder email to the group in like a couple weeks just to see where you're at and remind you guys.
Perfect.
good. Thanks so much.